There was a very interesting and satisfying case, a female in her 60s who came to see me in my office with a non-healing transmetatarsal amputation to her right foot. This was done for a gas gangrene. In the past, I had treated her for left lower extremity toe gangrene. After revascularization, she healed her toe and was able to salvage her foot. In the clinic, I made sure that she is on the best medical therapy with dual antiplatelet therapy and statins. And she had the normal atherosclerotic risk factors, which were optimized. The non-invasive study, as we do in all of our patients, showed the expected numbers of ABI of 0.3 as she was presenting with critical limb ischemia. After the clinic visit, we knew that she needed an emergent intervention for her right lower extremity for limb salvage, so I performed an angiogram on her in a hospital setting. As usual, I perform the angiograms with contralateral retrograde femoral access. I start with angiogram of the abdominal aorta and iliac vessels to make sure that there is no inflow problem. Afterwards, a selection of the ipsilateral limb is performed, and I do a diagnostic angiogram of the entire leg to study the inflow and outflow of entire vessels, especially in patients who are coming with critical limb ischemia. This is very important that we make sure that the inline flow is established from the heart to the level of the tissue so healing occurs. This angiogram revealed complete total occlusion or chronic total occlusion of her right SFA and popliteal artery, and also she had diffuse tibial artery occlusive disease. Only posterior tibial artery is patent. I started with my typical approach of recanalization through the contralateral approach, and I try to do this through transluminal or subintimal planes, whichever plane I can obtain. In this particular case, I was not able to start a subintimal or transluminal plane from the femoral approach. Therefore, based on her tibial angiograms, I selected to do a plantar approach, and I was successful in performing recanalization of the SFA and the popliteal artery. This saved her from a need of open bypass. Once I was able to establish my wire access through the CTO, I performed an IVUS, confirmed the true lumen presence of the wire, and thereafter did directional atherectomy using the HawkOne LX device. The LX gives me the versatility of knowing the side where the plaque is and to do a directional and intentional atherectomy instead of doing the atherectomy towards the side of the wall, which is thinner. After multiple passes, I did an IVUS again to confirm that the residual stenosis is less than 30%. And with this success, I then performed drug-coated balloon angioplasty to make sure that our result is long-standing and the restenosis does not occur quickly. After establishing flow through the SFA and the popliteal artery, our goal is to, in the same setting, to establish flow to the foot, as patients with critical limb ischemia need perfusion to save their foot. In this case, I had the wire access through the posterior tibial artery with the plantar access, but from the femoral approach, now I gained access and had a recanalization of the anterior tibial artery. And now I performed atherectomy with a smaller device, Hawk S, to perform atherectomy in the posterior tibial artery, followed by in the anterior tibial artery, and then I performed balloon angioplasty. And at the end result, you could see that she has inline flow from the heart through SFA, popliteal artery, and both tibial arteries to the foot. The thing which was satisfying about this case was after we intervened, antibiotics and local wound care, we were able to salvage her TMA. It has been a year since I intervened on her, and she is, as I said earlier, walking to my clinic and has saved both of her limbs by being compliant on the dual antiplatelet therapy, strict surveillance, and continued care with our entire team.